So can everybody hear me that's in our room 3 for cohort 3? This is Laurel.
I can hear you.
Yes, we can hear you.
Okay, great. We'll give everyone a chance here to come in and see if we have a few more people joining us. I'll give one more minute and then we'll get started. And when we do start, I'll have you each share your name and your organization. Okay, so we'll go ahead and get started. You guys have heard about me. I'm Laurel Avila, the navigator for Greater Columbia, and I'm leading today for our discussion regarding cohort 3. So we'll go from that, and I will, in my order, I think your order should be the same as mine when we click on participants. So Ed, we'll have you introduce yourself next.
Hi, I'm Ed Marash. I'm the administrator at Prestige Post-Acute and Rehab in Ellensburg.
Thank you. And a familiar name, Baljit.
Hi, Laurel.
Hi.
My name is Baljit, and I'm a data analyst at Lord's West Pasco Clinics.
And Victoria.
Hello, this is Victoria. I'm with Ideal Option.
Awesome. Hello. And Brittany, you met. Doug.
Yes, Doug Bolton, Helen Wilson from Garden Village in Yakima, skilled nursing facility dedicated to behavioral health.
Thank you. And Joshua.
Joshua Gartrell, Clinic Director for Behavior Health at Tri-State Hospital.
Thank you. And Rachel.
Hi, this is Rachel. I'm with Cadlick Clinics.
Welcome. And Brisa.
Sorry, I was muted. Hello, everyone. I'm Brisa Perez. I'm with Greater Columbia ACH, Community and Tribal Engagement Specialist.
Thank you. And Kelly.
Yes.
If you could introduce yourself and your organization that you're representing.
I'm Kelly Pease. We are from Tri-State Memorial Hospital and Medical Centers. We're in Clarkston, Washington, and we are a critical access hospital and clinic.
Thank you. And Wes?
Hi there, this is Wes Lucky. I'm the Deputy Director for the Greater Columbia ACH.
All right, and Andrea?
Hi, this is Andrea. I am Safety and Quality Coordinator at Hospice Chaplaincy in Tri-Cities.
Thank you, Andrea. Holly?
Yeah, this is Holly Kaiser, Administrator of Richmond Rehab and Prestige Assisted Living.
Awesome. Okay, I think we've caught everybody there. Thank you so much. That helps us to get an idea. Some of you I've met and some of you I'm not familiar with. So welcome, everyone. The first thing we wanted to have an opportunity to share information about is the budget and the budget reconciliation. So this is a milestone 1 requirement for those of you who have been doing this for a while. You realize that as the fourth quarter, we require a reconciliation. And then when you're starting out and first quarter of a practice year, we require a projected budget. So our next slide is a kind of overview of explanation when you're doing that proposed budget. So for you guys, for cohort 3, you're looking at getting this ready. It'll be due February 15th, and you'll be working on your proposed budget for practice year 2. Hopefully you're familiar with these categories. I don't want to take too much time, but I will give just a brief overview and then offer you an opportunity to ask questions about that when we finish going through the overview. So the first category is a new billing or electronic health record. An example of something that you would use this money for would be population health management or an upgrade to your current EHR. Some EHRs are more expensive than others, so it may be that it's just a part of your budget to get the new EHR depending on the cost. So it could be completely new, but that usually falls in your practice year 1 budget. For technical assistance, this category really more around population health management tools. As far as maybe a template development, if you don't have the ability to update your templates within your organizations, but you have to pay for an update outside of your organization. And I realize you might have questions and I might not want to read through all of them. So I'm going to stop there and say, do you have questions about things that are in your budget so that you're thinking about putting in your budgets for practice year 2 that you want to ask questions about for new billing or electronic health record system or technical assistance? Okay. Hearing nothing, I'll move on. So operating expenses, so those are probably most obvious, but things like your licensures in regards to using other, so for instance, if you have a patient satisfaction survey that you're using outside of your EHR, the license cost for that, office supplies, vehicle expenses, marketing, Zoom licenses, and things of that nature. So any other questions about what could be included in operating expenses? Okay. And then next for retention and recruitment of staff. So particularly challenging, it's finding some of these roles, data analyst role, the RN navigators role. So that's including costs that you might need to use to recruit and then retain the staff for those positions. So, I was just thinking how we are sharing that we have the ability to, we're using Zoom for the first time. And I do think that there is a option to be able to use like a thumbs up. Or Brittany, can you help me point that out?
Yeah, so if you look at the bottom of your screen, there's a reactions thing in your little toolbar at the bottom. And if you click on that, there you can say yes or no, or thumbs up. There's things. Are you wanting to use the yes or no, Laurel?
I think, it's because it's hard in our virtual environment to know, you don't say any, it's difficult to say. So if you're good, just give me a thumbs up on each one. And if not, go ahead and ask the questions. So that's just so I can see the feedback from you guys in some way. I'm missing seeing your faces.
So if you guys look on my name, I just did the thumbs up so you can see that. So if you want to be able to do that when Laurel asks questions, if you don't have any questions, or if you have a question as we're going through something, you can also raise your hand.
Was that, so I think I can see it. Okay, so let's practice, you guys. Did you understand what Brittany said and can you find it? Let's see a thumbs up if you got it.
Think I'm seeing
Rachel's
mine.
got it.
Oh,
I saw Ed.
I had to open the participants list so I could see the reactions.
Oh, that's what
Yes.
I'm missing. Okay.
Thank you. We're learning as we go here.
All right. Looks like we got several people. Looks like we've kind of found it. If you guys have questions, I am watching the chat box as well. If you guys have any issues, let me know.
Okay, so we'll keep going here. We have until 3:15 in our room here to cover the things that we need to talk about. Okay, so then after recruitment and retention of staff comes improvements to provider network. So direct secure messaging, interoperability type things. So even a phone system, but sometimes phone systems are so expensive that they would take all your entire budget. So, you know, within reason. And the patient portal, sometimes that's an added cost to you, or if you want to enhance what you have with your current EHR. Okay. Any questions? Or are we good?
So Laurel,
Yeah.
so would that also include population health management software too?
For the improvements to provider network.
The technical components that you just talked about, such as direct secure messaging, in that budget category, would that also include the implementation of population health management tools?
That one we've put more with technical assistance. But yes, it can go in the budget. It's just we would look for it under technical assistance. Thanks, Wes.
Thanks.
Okay, we'll move on. So for quality improvement, this is really, oh, I'm sorry, I skipped staffing. So that's one of our most commonly used categories. And just I wanted to mention about that is, you know, what we're hoping to see is initially, especially in practice year 1, that you would have more money in that and you're supporting those positions that you're adding into your organization. But then as we move out into year 2 and then year 3, that would hopefully become part more of your normal operations costs. So that's what it means when we say pay salary out for 2 years to make it sustainable. We want to be looking, you know, forward to having those positions be sustainable within organizations. Okay. Any questions on that stuff so far? Okay. And quality improvement is just time for quality improvement meetings, setting aside time for staff to attend. So you may capture that additional staff time by putting that in the quality improvement categories. And then support to implement integrated clinical models. So what comes to mind most readily is implementing the AIMS model or the BRE model for bidirectional, or introducing pharmacists to incorporate them for collaboration on care teams for patient care and self-management support. And then the last category is staff, especially time, you just setting aside in your budget, looking at time to attend provider trainings, meetings, collaborative meetings. So lots of time from patient care that would be incorporated into this category. And then as far as the last one, upgrades for other upgrades to computer network, new examples or new exam tables, or we've had a site actually put monitors, big screens in the waiting rooms to give information to patients that are waiting about what their programs are or how they can get help after hours, information about care that is provided within that organization. And also remodeling, and more, not like a total construction of a new building, but remodeling within your organization to have better accommodate practice transformation workflows. So having finished that, that's a lot of information for one slide. Does anyone have any particular questions or Anything as you're thinking about your budget coming up for year 2 that you want to ask about? Okay, sounds like you guys got it. And of course, you know, any questions that you have, we will give you this information. You'll get the slides when we finish our Learning Collaborative today, and you can discuss that with your practice transformation navigators as you get ready to get your budget put together. Okay, so the next thing is the reconciled budget. So as we think about the reconciled budget, that's the bottom half on milestone 1. That's for you, and cohort 3, that's due with your reporting that was due today. So the only thing that you need to worry about is if you're greater than 15% over or under your proposed budget, in which case you'd need to fill out the narrative box at the bottom and just explain what happened. You know, so you had additional staffing costs because you had to retrain someone, or you have 1 provider instead of 3, or what happened with your budget that it was different. So hopefully everybody got that. I know that we've been talking about it with sites I've been working with, but does anyone have any questions about whether or not they need to do it or how they need to do it? Okay, perfect. Okay, so the next topic that we're going to move on to after budget is talking about the mandatory items in your milestones that are coming up with year 2. And again, I'm sure that you've been having these discussions with Brittany and Martine and I. Well, not Brittany, I've been covering for Brittany, but you'll continue to have them with Brittany as she's reassuming her role. But there's a lot of different areas for mandatory reporting items. And it's not my intention to go through each one of these items on the slide, because you are seeing these things mentioned with your visits, with your practice transformation navigators. But what I wanted to do is just highlight a few of them in the upcoming slides, and we could have some discussion around that. So I just wanted to give this as an overview of some of them. And if you have any questions on any mandatory items that I don't cover, we will go back and discuss that as well. But this one is one that we see a lot of people kind of wrestling with and trying to figure out how to screen and then use social determinants of health, and then incorporate that into their risk stratification methodology. So what I did was, we just have a screenshot here from our reporting portal that shows the milestone of 2A risk stratification methodology and types. And that requirement, year 2 requirement here, is just that you incorporate the social determinants of health. So I don't think I have anyone here but representing, but we have a site that decided to use, actually Andrea, I think you guys for behavioral health started to use this one. And it's the American Academy, I can't read it, but family practitioners or family providers. That is a quick 12 question screening for social needs. So just a quick question out to you guys. I'd like to go out and see if we can pull in anyone who's currently screening for social determinants of health, and if they could share what they're doing in regards to how they're doing the screening and then doing the follow-up as needs are identified. So Andrea, can I go? I'm sorry, but can I just pick on you for?
No, it's fine. I was trying to figure out how I was going to answer. And I wish I had a better answer for you, just because I don't go through the tool with the specialists, when they do it. So it's hard to answer you, but I do know that we are utilizing this screening tool.
Yeah. So Teresa started to use it and started to incorporate that into the beginning of her visits as a therapist with our patients. But do you know anything about the follow-up and how, when the needs are identified, that who's working with them to try to address if it's a housing insecurity or food or access to primary care, that sort of thing?
No, I'm not sure. I know that she has a couple of different places that she reaches out to. I thought like Miramar or something, she got special decision aids and stuff that she was handing out to people for this thing, but I don't know if it's 100% been implemented.
Okay. Okay. Anybody else on this one have anything to share on how they're screening for social determinants? Have they incorporated that into risk stratification? I know it's a difficult one, so I was just hoping to glean from someone that other people could benefit from. My sites are not going to be happy with me. Holly. I just know that you guys do a great job. So Holly, would you mind sharing just a little bit about how you guys do that with your setting?
Sure. Well, and I know Ed is skilled nursing as well. And as we kind of talked about on our call this week, then the nice part about being part of the skilled nursing facilities is that we are so regulated and have so many systems in place already that are mandated by the state and federal government that just kind of by default, we already meet this criteria. So I would say for us, this screening process is done on admit with any patient. We're going through their prior level of function, living arrangements, challenges they have, and then we continue to discuss that all the way up in my setting up until discharge, because most of my patients discharge back to the community. And so at that point, we're really going through challenges that they've had or continue to have, anything from, not having a primary care provider to Meals on Wheels, and then are working with them to try and implement and connect them to those resources.
Great, thank you so much. And that's great to hear from you.
Yep.
Also, I know that, Rachel, I'm not quite sure how familiar you are yet. Rachel's with Cadlick and has just started here in the last few weeks, but she's been working with the team-based clinic at Cadlick. So is there anything you can share with how you guys have started to incorporate it in? I kind of wanted to pull in someone from primary care to talk about, potential that how you're capturing that within your EMR, and you guys have Epic. So is there anything that you can share with us about how you're planning for that with your team-based clinic?
I have been looking into some like trauma-informed care surveys, and I know we do the PHQ, but I am not sure specifically how we'll be doing it yet. It's
okay.
Just too new for me.
Yes, I'm sorry. Thank you for sharing. I'm sorry to put you guys on the spot.
No, fine.
Yeah, just to get, we're basically, this is a year 2 requirement. And, so anything that anyone is doing already is ahead of the game. So it's not that you would have had to do it yet. But some of you who are Cohort 3 sites that have had Cohort 1 doing it for a while might have something more to glean. I do know that it's helpful when it's built into the encounters, as far as the templates for documentation. Sometimes under social history, you go through and ask the questions about more of these social determinants of health. So we really just are encouraging you to start and to think about, transportation, housing, food insecurity, those types of things. And then how the workflows associated with that of, okay, so when they say yes, then do we have the resources in place to help those people get connected to the resources that are out there for them. So thank you all for sharing. Did anyone have anyone else that they wanted to share with the group? Okay, now we know I call on people, sorry. Oh, okay. So another area of mandatory reporting is in relation to reports. And so really in year 2, we're moving more towards that data and trying to find, really trying to come alongside all of our sites and helping them come out with some of those outcome measures that reflect some of the work that you've been doing over time. So one of those is the, one of the milestones ask you to upload a report showing the impact of self-management support based on the measures that are selected in the previous question. And I'll just mention all of them first and then go back into it a little bit more in detail. The second one is to upload a report showing integration of bidirectional care. And then the third one being uploading a report of de-identified CQM as clinical quality metrics. So upload a report of de-identified clinical quality metrics for individual practitioner or care team. So again, some of you are already doing this, and I just kind of wanted to demystify this for everyone. So when we look at an example, this is from the PAM, the Patient Activation Measure, and some sites are utilizing this in regards to how the patients are responding to questions, and those are documented. And within that, then they're scored. And you can look, there is so much data that's provided there that can show, okay, so we're using this, working with our patient in this way to have them self-manage or set goals and be part of their planning for their care plan. And as they are more incorporated into that, then their activation level improves. So these scores are an outcome measure that are reflective of people moving from one level to another where they're more activated or more ambitious about meeting their healthcare goals, being involved in their plans of care. So that's just one example. Is anyone in our group today utilizing the PAM? Okay. I know we have a couple sites, but you guys may not be familiar yet. This is just a simple report from an example for you guys of your CQM data. So, you know, some of you may have chosen some of these same items for your clinical quality metrics. For example, the diabetes care, the hemoglobin A1C testing and showing. So this is, you know, just to help you know that it doesn't need to be a huge report that's really fancy or anything like that. It can just be as simple as a patient count, you know, so 2 out of 6 patients the first quarter fell within the parameter. And then it just shows some improvement over time. So 4 out of 6 and 7 out of 9. And then patients, number of patients screened for depression and follow-up for adolescents and adults, and then over the total number of patients impaneled. So again, you know, not huge numbers here, but, you know, it's just showing where you're at and gives you something to share among your quality improvement team within your individual organizations. So I won't continue to go down to explain in detail each one of the metrics, but I just wondered if there was an opportunity for anybody to share if they have something like this that they've been able to do in their organizations yet. It's a year 2 requirement, but in case you've done it yet. Okay. Hearing none, that's okay. I hope this helps you see an example of where you can head, you know, just to get going on this. And even if you start small and then, you know, add more items into your report as you move on, that would be great as well. The third slide here is another example, and this one is a primary care site, and really it's more of a simple that we're doing okay, and green means we're doing fine and kind of at the same level that we were last time we measured, and then green, and it's an improvement from last time. So just really simple, high level kind of report. They have other things in their normal, their GCACH practice transformation quality metrics. They've included others that they just have everything together in one report. But this is part of a newsletter that goes out to all the clinical staff members on a monthly basis. So that's another way to show a summary of your clinical quality metrics to upload for that required year 2 requirement. And that's under milestone 5. So I can stop there, but I'd kind of like to go back to have pick on another team person. So as far as what you were seeing, Baljeet, are you able to share anything with what we've been able to report from Lourdes as far as clinical quality measures and how those are reported out to the team? Is there anything going on with that? Did she drop? Looks like she's not there. Okay. I will move on. And the next thing we wanted to talk about was a requirement to have the pharmacist engagement in the clinical care team. So this is just thinking about the one question that says collaborative drug therapy management is mandatory for contracted or staffed pharmacists. So for instance, in this site, they chose anticoagulation, but there are other conditions that pharmacists could include their input on as part of the care team. So this doesn't need to be a requirement that you do for 40 hours a week. This could be even 1 hour a month for the pharmacist to be involved in your care team meeting. Perhaps you have a list of patients that you'd bring that would have more complicated condition or several medications or more than one chronic condition. And then the pharmacist could weigh in as a part of the team to make suggestions on changes that would be helpful for the patient. Another way to start out would be just to arrange a certain amount of time, like 2 hours on a Thursday afternoon, that if a patient had a question on their medications that maybe they weren't tolerating them, or in regards to side effects or things, that you could arrange for appointments to be made that they could talk to the pharmacist. So I know that sometimes that might be helpful for our behavioral health sites when patients have several medications and are trying to sift through side effects or may have questions in that regard. So we feel that pharmacists have a lot to offer and can really help that patient-centered care meet more of the needs of the patient than if they were not included in the care team meetings. So is anyone utilizing the pharmacist as part of their care team meetings now?
We are not, but I did have a question. This is Victoria with Ideal Options. So we do, MAT services, and we work with pharmacists every single day, and we're on the phone with them all the time and working together, but we're not necessarily employing pharmacists or have pharmacists at our actual clinic. So is this something that we will need to do in year 2, actually like have a pharmacist that we hire that we work with? Or is the relationship that we currently have with our pharmacists good enough?
Good question. Thank you, Victoria. So what we, in the scenarios that can happen in that sort of situation is coming up with some kind of a MOU or collaborative agreement with the pharmacist to have them, this is someone that you've had good experience with, that a lot of your patients end up, maybe a lot of them end up using the same pharmacist. So whatever makes sense, that person is more likely to be someone you would want to collaborate with. Just to get together and say, okay, so, these are our patients that we're seeing. And if my my MAT provider had any particular questions about other medications that the patient is on and interactions or things like that, how would that look, to make that most advantageous for both individuals involved in that. So does it really need to be a financial agreement or that they need to be employed by, but just even having in place some type of an agreement that they would be available. And it's been, interesting to see really there's sometimes an open door when you wouldn't imagine it would be. Like they're really excited about being incorporated into kind of coaching along patients or providing extra information for providers. So it's just coming up with that agreement to make it a little bit more formalized and also make it streamlined for the patient so they don't have to come in cold and say, you know, I have a question about my medication, but if they're already incorporated and understand more about that patient, it's going to be better information and kind of a warm handoff more type thing than if we didn't have an agreement in place.
Okay. That makes sense. Yeah, I mean, I think Rite Aid on not Eli, the one by your guys' new building, actually. That's probably the one we work the most with at our Kennewick location. So we could probably just have like an MOU, especially with one of the main pharmacists that we always work with and talk with. And I'm sure that would be something much easier. Yeah, that's a much easier approach than I was initially thinking when I saw a contracted pharmacist. So
exactly. Yeah, you know, it's a tough kind of threshold to imagine going over. I know that when we, I shared that I was working at as a director before, and when we started talking about having a pharmacist as part of the care team, I was like, how are we ever going to get that? But, you know, it really worked out, and I'm not sure how that's going right now because Martine works with that site. But it was just, they were really excited about coming on board and being part of the care team, you know, and something that they were very interested in. So it's a very advantageous thing for our patients.
Mm-hmm.
Okay. Any other questions on that one? Well, it looks like we are very early. We have like 30 minutes to spare. I can leave some other options for us to share information about if you guys have any questions about any of the requirements for the reporting requirements for year 2, since we have extra time. Would you like to hear about that? Sure. I don't even see Brittany's thumb up on that one. So, okay. So we'll look through here. MCO rosters is one that is trying to have, and let me pull up that slide. So this one for primary care providers is an important one, to be able to look at your MCO rosters or pull your MCO rosters and then pull your patients from your EHR and see if they match up. And as this example demonstrates, they often do not. And so just coming up with a process to try to address that in some fashion. So do you have any questions about that one?
This one doesn't apply to
it doesn't apply to behavioral health.
Okay, because I was gonna say this one didn't make as much sense on our end to fill out.
Yeah, it doesn't. This is really for primary care.
Okay.
So Brittany just brought something to my attention, which I am so sorry that I left off, which is one of our main points of wanting to talk with you is I'm going to just shift gears here and go back to our revenue sharing model and share my screen with you in regards to what that looks like. So let me see if I can. There we go. Sorry about the delay. Okay, so are you guys able to see this screen that says Cohort 3 and talks about, has an Excel spreadsheet up?
Yes.
Okay, So what I wanted to do was just talk a little bit about the year 2, your amended contract, and hopefully all of your organizations have seen those and are familiar. But what he wanted to do is go into a little bit more detail about that. So on the first section, when you look at the where it says milestones and it's black, let me see if I can, here, when we run down here, that is the individual milestone that's associated with this revenue sharing amount. So that's what this column is. Now, this group here is the revenue sharing that's associated with each individual of the milestones. What is on this side is the payments that are coming out that you would see when you get the email that says care management, milestone 2A, 2B, 3A. Those are all combined for this one amount on each quarter. So that's these dollar amounts totaled up to this. So as long as you met milestone for empanelment, for medication management, for access and community continuity, and patient-centered interactions, those are each 1,125, but you'll see it paid out as 4,500. So that's why we have this separate column over here. But what we wanted to do is just show you some of the things. So starting up here with budget development, when you develop the budget, that's in the first quarter of the year during January, February, and March, and that's due. And if you've completed that successfully, the revenue sharing dollar amount is 1,217. And then not again until the fourth quarter, that's when you'd have a reconciled budget due. And that's where the $1,217 would be paid during this. You achieve it during this, and it would be paid for that reporting period of October, November, December. Okay, so I'll stop here and say, do you guys have any questions about this so far, what you're seeing? It's kind of complicated. Okay, crickets. All right, that's good. I hope that means that you all understand. And again, if you don't want to ask particular questions within our time here together, your practice transformation navigators can help with this. Okay, so we talked about budget development and care management. And then the next category is for risk stratification and risk stratification statistics. So risk stratification is your methodology, and then the reporting of the statistics associated with that. So you'll see that those are also paid together with opportunities at risk. So when you see that referred to, when you get your email back, you'll see the amount for each quarter being 2,250, 2,250 for a total of 9,000 that's able to be achieved during the year for those two items. Okay, and then this is another grouping. So self-management support, the revenue sharing amount for that is 1,125 per quarter, and the same with the shared decision-making for A2, and that's the dollar amount associated with that. So, you know, if you combine the 2,250 that's available for revenue sharing each quarter, the amount total for the year for practice year 2 is 9,000 for those two items. And then for bidirectional integration, that one actually is paid out by itself. And so it's 3,649 each quarter for a total amount of revenue sharing for 14,596 for the year. And the same thing for a quality improvement team. So that is just showing that you have met with your quality improvement team internal on a monthly basis, and also with your practice transformation navigator. And that's the dollar amount for each quarter. And then the total amount for $15,000 a year. And so and those are paid out individual quarters for the total of 15,000. And then as far as reporting, so these are paid out together. So clinical quality metrics. So just identifying those clinical quality metrics and providing that 5A2, that report about a summary report about your clinical quality metrics. That's combined with your MCO reporting, roster reporting, or what that slide I just showed you about, here's what our MCO shows that we have assigned to patients, and here's what our EHR assigned to patients, and trying to bring that together. So that MCO roster reporting is $1,000 each quarter for a total potential revenue sharing of $4,000. But since those two are combined, what you'll see is it will pay out if you meet the milestone to $7,731 each quarter for a total of $30,924 for the entire year of practice year 2. And then the practice transformation implementation work plan. So that's just your work plan that you refer to in meeting with your practice transformation navigator. And each quarter, that's the amount that you're able to achieve should you meet milestone, for the total of $4,868 per year. And then here on care coordination, all of these items are paid out together. And this is the one that you might be familiar with in reporting. For year 2, you need to have all selections of A, B, and C. And that is, the A is that you're following up on patients that have been had a hospitalization and have received care management after that. And then selection B is in reference to the emergency department visit follow-up. And then C is the care compact and agreements that are in place. And then there are different ways to meet that, whether you're a hospital site or a clinic site. So with the hospital follow-up, the hospital needs to identify the patients that do not have a primary care provider and make a referral. And that's the same thing for hospitals with the emergency department visits. And so meeting all of those milestones results in the total revenue sharing of $17,732 for the year. And I'd like to say too, we have the ability to say you're doing well on one component of this and you're unable to report on a different component of it for one reason or another. You won't lose the whole amount. We can do a percentage of the payment for the parts that you're meeting when there are several items in here. So that's the same, like when you look at care management. So if there's something that you were not meeting, you wouldn't lose the entire $4,500, but a percentage of this. So if you missed one, you would get 75% of that payment for revenue sharing. Is there any questions on that concept? Hopefully it's because I'm explaining clearly, because it can get confusing. And then this one for training and learning collaboratives for 7A1 training and mentoring, and 7A1 as far as practice transformation learning collaboratives and attending those are paid together each quarter. So $5,475 to equal a total of $21,000 for those two. In the specific attended, helping us to know that you've attended. And then also that's where the stories, where you're spotlighting your success stories, you're highlighting that story for us so that we can share it with other sites. And then the attestations that you have collective medical, direct secure messaging, and One Health Port. That's revenue sharing is $1,000 per quarter for a total of $4,000. And then a lot of our sites, we've been working hard on getting the patient-centered medical home assessments completed and the Maine Health Access Foundation health assessments completed. Those are meant to be completed at the beginning of each practice year. And if they're not, whenever they are completed, the amount will be paid out at the quarter that it was completed. So, and the total amount that's available for the year is $1,000 for the completing the PCMH and $1,000 for the MEHAF, for a total combined amount of revenue sharing for $2,000 for the year. So the total maximum available revenue that's available for meeting all milestones is $149,454 for per site for your practice year 2. Does that make sense, everybody? Thank you. Any questions I can help with?
So if we do have that 15% difference and we provide an explanation, does that mean like we won't get it because it was a 15% difference?
No, we are able to carry those funds forward to your second practice year.
Gotcha.
We just it's really, it's important for you guys to have an accounting and a trail for where the money's been spent should we be audited. So
And mainly we spent more in other categories versus other categories that we initially thought we were going to spend them in. And some where we didn't spend much in those at all and much more in others. So
yeah, and I think it's helpful to just go ahead and go through all the categories and fill in for milestone 2. Milestone 1. Like, are you guys able to see? Still, I'm sharing from our portal.
you're sharing something on the screen now?
Yeah. So are you? I must not have shared my screen. I probably shared just that one spreadsheet.
Yeah, no, we can just see the spreadsheet, Laurel.
Okay, thanks, Andrea. Let me see. I'll stop and show this so you can see. There's Brittany's baby. Okay. So just so you know what we're talking about. So basically on all these categories, if they shift around, that you would need to fill in, you might switch them out. I just think it's easier to go through and put actually what was spent in here, but it's really not required unless you actually were a greater than 15% over or under.
Oh, gotcha. Okay.
That makes sense.
Yes.
Okay. And then up here is like the one. So.
Laurel, this is Ed Marash. Can you hear me?
Yes. Hi, Ed.
We are probably more than 15% under what we had intended to spend due to COVID. We had planned for some people coming in and doing some remodeling and that type of thing, but due to COVID, they were not able to do that. Can we carry that forward to the next year?
Yes.
Okay.
Yeah. So you just, Ed, you just want to make sure and include that in your narrative section, that little box at the bottom of the milestone.
Sure.
And,
okay.
And then make sure that Martine knows that, that's when you look at your next year budget, you can include that amount when you're doing your proposed budget for year 2, along with what we just saw for the 149,000.
All right. Thank you, Laurel. I appreciate it.
You're welcome, Ed. Anybody else? Any other questions around budget or revenue sharing that we could help with? And some of it's pretty, very straightforward, but some of it isn't. So, be sure as you have questions, and you'll get all the slides from this when we're ready to meet again with our practice transformation navigators. So would you guys like to go back over as far as any of the information on mandatory reporting areas, your preference? I can check back in with the main group and see if other people are done as well, or if what would you like to do with the 15 minutes of time that we have left?
I don't think I have any questions on it. You went through it pretty thoroughly. Thank you.
Oh, you're welcome, Holly. Okay, let me just send a quick message to Chelsea and let her know that we're done. Oh, okay, absolutely. Why don't you guys go ahead and take 10 minutes? So whoever wants to take a little break, that's a great idea. Thank you. Kelly. And so come back in 10 minutes and we will wrap up and then switch over to going back to the main session with everyone else. Thank you all very much.
Thanks, Laurel.
Thank you, Laurel. Nice job.
Okay, thanks, Wes.
Good job, Laurel.
Thanks, Risa.
So Laurel, I guess I'm going to go ahead and stop recording and then we'll exit our breakout session. Is that correct?
Yeah, I was trying to remember how to message the host, but I don't see it on here.
I think it is. Huh. No, my button I had last time isn't here.
Okay, I'll just
Hey, Laurel, I see that you guys are recording this session. Is it possible to share it with us?
Yeah.
Yeah, Baljeet, you'll get them. They'll come out at the end of the meeting. Chelsea sends them out to everyone, so it'll be recorded. And
Okay.
it'll also be, you can go onto the portal and find it under recorded. It'll
have
say
Chelsea with us.
Yeah, the reason why I was asking because I got this invitation forwarded from someone else, so I may not be on the distribution list, so I will not be able to get it if you guys send it to the same distribution list. So that's why.
Oh, okay. We can add you to the distribution list.
Okay, sounds good. Thank you.
Laurel, I have Chelsea here.
Hey, did you guys need me?
Yes.
Sorry, I just took a drink. We're finished. We're on a bathroom break.
Okay, I saw some of your folks returning to the main room. So that's, if you guys want to just go ahead and head in there and take a bathroom break, I'll make sure to note that in the main room.
Thank you, Chelsea.
Thank you.